Okay, I'll call to order our ad hoc meeting. And if we could start with introductions.
Tim Steele.
Bill Evans. And for our audience, if you could introduce yourself for the record, please.
I'm Kathy Veltri, just an educated citizen. Venus Woods, Alaska Native Justice Center.
Greg Razzo, Siri Vice President.
Denise Morris, Alaska Native Justice Center.
Jeff Jesse, Mental Health Trust Authority.
Joel Catteroach, the Odom Corporation.
Michelle Baker, South Central Foundation.
Shane Coleman, South Central Foundation.
Chris Whiteman, South Central Foundation.
Carmen Springer, Anchorage Coalition to End Homelessness.
Christopher Constant with Fairview Community Council and Business Association, but I was told today that if I had to, I could speak for Aquila, but I don't want to, but I could.
Steve Ashburn, Anchorage Department of Health and Human Services.
Rosella Young, Assembly Legal Assistant in the Assembly Council Office.
Warren Jones, First Covenant Church, AFAC.
Janet Jones, First Covenant Church, AFAC.
Jerry Jenkins, Anchorage Community Mental Health Services.
Lisa Aquino, Catholic Social Services.
Corey Anchorage Downtown Public.
And Nick Training, Subway.
Okay, thank you all for coming. We have a number of really good speakers today. The general overall theme of meeting today involves mostly Alaska Native issues and how they impact this issue we've been studying for the last year or so. Our first presenter is Michelle Baker, Acting Vice President, South Central Foundation. So, Michelle, the floor is yours.
If you would like to have an
Yeah, sure.
That's great.
Yeah, wherever you're comfortable.
Good morning. My name is Michelle Baker. I am Acting Vice President for Behavioral Services. I am also Yupik Eskimo from the village of Caligari, which is on the Nushagak River in Bristol Bay. And we're here today to share with you a little bit about South Central Foundation, the services we provide, and talk about how our services, how we work with all Alaska Native people, including the homeless and the chronic inebriates. So just to give you a little overview of South Central Foundation, South Central Foundation was incorporated in 1982. We get our tribal authority to operate from Cook Inlet Region Incorporated. Our vision is a Native community that enjoys physical, mental, emotional, and spiritual wellness. And we do that by working together with the Native community to achieve wellness through health and related services. We are a customer-owned healthcare organization. That means customers, we don't call them patients, we call them customer owners because they own the healthcare system. And we provide services in partnership with them. They provide feedback on what they want to see, changes they want to see, and how they want their healthcare system to look. We do this in what we call our operational principles. Alaska Native people are very relational. We do everything in relation to the community, to the family, and so our system was designed around relationships, and our operational principles spell out relationship. Everything that we do is in relationship with each other, with the customer owner, with the provider, with our community partners, and key stakeholders. That's an important aspect of our NUCA system of care. And over the last 30 years, South Central Foundation has transformed how we approach healthcare to achieve whole person wellness by focusing on cultural values, through shared responsibility, through relationships, and commitment to quality. And most of you know that in healthcare, it's not easy. Healthcare involves very messy relationships with family, with households, and partnering with individuals that have complex healthcare needs is very challenging. And as a system, we have, it's our goal not to fix people, but it's our mission to partner with customer owners where they're at in their healthcare journey. They might need many things from us or that we feel that they need, but we meet customer owners where they're at. If they're chronic inebriates and they just want one thing, that's what we will do for them. Our healthcare system is designed to encourage relationship, to encourage partnership. Our customer owners are a panel to the same provider so that over time they can build those relationships, and as relationships are built, our hope is that customer owners would share more of their story, open up more to us, and allow us into their journey so that we can help them in that partnership. So in behavioral services, South Central is a large organization. We have 80 different programs, 1,700 different employees. In behavioral services where we work, we have over 20 programs, 300 employees. We do everything from peer support to outpatient behavioral health to residential treatment programs for youth and women for substance use. My team here today is here to kind of share some of the innovative things that we've been doing in behavioral health over the last 2 years to meet customer owners where they're at, to provide timely access to services, and as the funding gets tighter and the needs are growing in our community, to provide more population-based care to meet the needs of all the people that are coming to our programs. And so with that, I'll introduce Dr. Shane Coleman, who will speak to what we do.
Thanks. So I'll introduce myself a little bit, maybe give you guys some background. The premise I'm kind of operating under today is that we're here as a resource for you guys, hopefully to answer any questions that we can about whether it's alcohol as a disease or alcohol in the homeless, those kind of things. So, so that's kind of where I'm coming from. So please make this as useful for you as you guys want. Feel free to interrupt me, ask questions, whatever is kind of necessary. I have chosen some kind of key points, just discussing, kind of highlighting some things that I would think would be important in thinking about alcoholism and treating alcoholism. Also to give a little bit of a background on how we treat alcoholism within our system of sorts. And then about the, highlighting pieces that you might want to think about how do I treat this condition in this population, etc. So I'll try to highlight some of those things. If you have questions, please ask for it. If you need to redirect me to make me more useful for you, please do so. So that said, my name is Shane Coleman. I'm from Alaska. I was born and raised here, although I'm not Alaska native. I participated in the WAMI program. I matriculated at the University of Washington there. For med school, did an adult psychiatry residency over at Harvard in Boston. The adult mental health or psychiatry world includes substances, so it's one of the subsets or areas that we get training on, and I consider it one area in my field which kind of spans many areas. I also did a research fellowship at UW afterwards that focused on the interface between mental health disease and chronic medical disease, and kind of understanding the interactions and how that affects the health services world, which would be any kind of health-related system, even public health. I came with a master's in public health. And so I have a pretty general, broad background with relation to thinking about something like chronic alcohol use and medical disease, etc. So I think the first thing I want to highlight is just that, I think the kind of modern day view of alcoholism, particularly in a population of homeless individuals, is that it's really a chronic kind of remitting, relapsing disease, not unlike other chronic diseases, whether it's diabetes or other things. And the reason why it's important to think about that is because it's not a cut or a scrape that you come in, get sewed up, boom, you're treated, you're good to go, right? we start thinking about years and years of treatment. We're thinking about ups and downs. We think about coming in and out of treatment. We also think about the necessity for varying levels of intensity of treatment, et cetera, to try to treat, what is really this chronic disease that has far-reaching repercussions psychosocially and also medical health, basically. So if you have alcoholism and diabetes, you're worse off than if you have either one alone, if that makes sense. In addition, I would say that it affects kind of the attitude or like how you think about treatment. So for instance, we've recently, as an organization, kind of moved towards adopting the view of, there really is no failed treatment. It's really about trying to match the need of the customer, owner, or patient with the treatment. So, if you're seeing me as a primary care doc and I'm prescribing a medication that helps with substance use, alcohol included, and all of a sudden you relapse, we encourage our docs not to think of that as a failure, but to sit down with somebody and discuss and say, hey, what's going on? It sounds like we're having problems again. We're basically having a flare, right, of this chronic condition. Are there things we can do to support you? Do we need to get you to a higher, more intense level of care? Whatever's going on, right? Is there something psychosocially going on in your life that we need to be talking about or addressing, et cetera? So I think that's kind of an important frame of mind to have, that this is, ongoing. And we expect ups and downs. They're not surprises to us. It's actually what we expect in the course of trying to help somebody through a disorder like that. There's also, kind of a biological and environment component. It's a very complex, complicated disease. If we transition to kind of how we handle it in our system, our philosophy is to try to give people the best access to services that we can, access that is convenient for them in the moment that they need it, and that's kind of dispersed throughout our system. So if you show up in primary care, we have something called the behavioral health consultant that you can have access to. They're trained in a method called SBIRT, which is really a brief intervention and screening for kind of substance use or substance use disorders. And it ends in a structured kind of brief intervention and then referral to treatment. And referral would be to any of the other resources that we have throughout the system to treat that substance use disorder. So that's one example in primary care. If you show up in the emergency room, if you're homeless and you have an alcohol use disorder, the odds of you showing up in the emergency room are greatly increased, of course, which has all sorts of repercussions, increased costs to the system, et cetera. But we have something called the BIRT team, the Behavioral Urgent Response Team, that will show up. It's kind of a master's level clinician, not all that different than a BHC that we talked about in primary care, who would also be able to administer an SBIRT for you, which again is engaging, a chance to engage with somebody, give a brief intervention if they want it. I'll get back to that in a little bit about that if they want it piece, because that's can frequently be a challenging barrier to get past. But we have an SBIRT type model interaction there and can connect them to services. We're able to treat alcohol use disorders and other substance use disorders via the primary care physician. We also have co-located psychiatrists in addition to the behavioral health consultants who live in primary care. So you have direct access to a psychiatrist and to prescribing mental health or basically medication-assisted treatment for substance use disorders right there in primary care. We also have 4 Directions. I'll probably let Chris talk a little bit more about the specifics because he helps us run 4 Directions, but it's what you think of as an intensive outpatient program. So, primary care might be one level of treatment, getting engaged with mental health or with a psychiatrist might be another level of intensity of treatment. And then we have this intensive outpatient program, which means you go to that program multiple times a week, so it's yet even a higher intensity of treatment. And then we also have, for example, a residential for women with substance use disorders. And the residential, of course, is where you actually live there on site, which is why it's called a residential, for some number of weeks while you're undergoing treatment. So that's yet even another increased level of intensity, if you will. And that might give you an example of and how you could start thinking about matching an intensity of service with the level of need of the patient or customer owner with a substance use disorder. That is, they may need to be in the residential for 4 weeks, and then we can kind of work them down. Maybe they need to go to the IOP, the intensive outpatient program after. And then finally, maybe once they're more stabilized, they can do quite well in primary care. You've seen the primary care doc occasionally, or maybe the BHC or things. So that's kind of an overview of our services and the way in which we interact with folks with substance use disorders. So then kind of shifting gears a little bit to thinking about treatment and the things that I would say are important to consider, particularly in a population that may be homeless and may have pretty severe alcohol use disorders. The first place I would start is that engagement for that population. So engagement is key. Engagement is the part of treatment that starts with a generation of a relationship, building trust, compassion, understanding somebody, building empathy, and making sure that both parties are kind of on the same, on a level playing field and understanding one another, and that it's that initial piece of wanting to help somebody get better, basically. That's different for different folks. For a lot of people in this room, that's probably a fairly easy process that starts when we go see our primary care doctor the first time. But in a population like this, where you're talking about somebody who's homeless with a severe alcohol use disorder, odds are they have probably quite significant comorbidities, not only medical but psychiatric. And so I would just say that you really have to be thoughtful about the engagement process. You have to go to them, for instance. You cannot expect them to come to a clinic. That's to say nothing for the psychosocial challenges of not having transportation, housing, all that kind of stuff, right? Those are just raw barriers, which are significant. But the engagement piece is important, I'll just say. And so an example of how you get around something like this is there's something called like ACT teams, for instance, where your job is actually, you don't go to a clinic to practice every day, you go out into the community. So you go find where the homeless folks are hanging out. And you might start with an olive branch of sorts. So you might have sandwiches. In residency, when Boston, when I worked with this population, we would do just that. We had a backpack, we had some socks, and we had sandwiches. And that's what a lot of homeless folks want and need. And so you would start, after 2 months of meeting somebody and seeing them once, twice a week on the street and handing them this kind of things, all of a sudden you start that engagement process and you can have conversations that you would never have otherwise with folks in that scenario. So I'll just highlight that that it's a population that requires you to think about their needs specifically, which are very different than what you might think of in a general medical setting or hospital system or outpatient system or whatever. And that engagement piece is key. And I'll just highlight also, in getting back to the volitional piece of treatment, right? Engagement's not only important to start the conversation, but ultimately the way our society approaches substance use disorders, we have really one option, and that's to get the person who needs help to accept help. And so engagement is not just necessary, it's mandatory in order to start that kind of journey, if you will. I've already highlighted a little bit of the psychosocial needs, but to not think of housing, transportation, even vocational needs maybe a little bit later on down the road when someone is able to enter treatment, get ALOS. Without thinking about those needs, you may as well not even start treatment, because what's the point? It's a complex condition usually, especially in those that are homeless, that requires kind of a multi-pronged approach to think about success really. And then I'll just highlight, the other thing too is that options are always really good, right? No one single glove tends to fit everybody. And so we've highlighted anything from, this ACT team type thing, peer supports, right? Engaging others who have been through these kind of conditions or situations and have somehow found a way to stabilize themselves, recover, heal. They can be invaluable in these kind of tools. Faith-based for those that are faith-based, 12-step, you name it, right? There's a whole lot of different options, and being able to have some sort of option or choice is, I think, pretty key for folks in general, Alaska Native folks included, in trying to think about which journey best fits me or will give me the best chances of success, if that makes sense. I might kind of stop there and transition to Chris so he can talk to you guys a little bit more about some more components of treatment in our program that are kind of key, both with Alaska Native peoples and homeless and alcoholism.
Okay, so my name is Chris Whiteman. I'm the clinical supervisor at our Four Directions program, which is a outpatient substance abuse program, a more traditional treatment model. I'm originally from Salt Lake City, Utah. I've been in Alaska for the last 4.5 years and with South Central Foundation for that period of time. About 16 years in this. So there are a few things that we're doing, changes we've made in our program over the last couple of years, some of which directly apply to chronic anemia population. And one of the big ones is is we still have our kind of traditional treatment where there's a point where you enter treatment, there's some specific requirements about you attend these particular groups at these times, and that's really effective for some folks. For a chronic inebriate, there are many barriers to somebody, an expectation of 9 hours a week at specific times being in our program. So we've, at SCF, over the last couple of years in general, we've added a lot of kind of drop-in learning circles. So that doesn't require an assessment and a treatment plan and a formal engagement with the customer. There are a broad array of supportive groups where, if they show up this week, great. If they don't come back and they're not able to get there next week, that's fine, and they can come the next week. And try and spread them out throughout the week and throughout the different times during the day. So in the hopes that by not having those expectations in a traditional treatment program, at some point, if somebody stops coming, we have to discharge to give that room to somebody else. In these open learning circles, they can come or not come, and there's no necessarily consequence or discharge or treatment failure associated with that. So that's one of the things we're doing. One of the big barriers that we have in general, there are a couple that I'll talk about. One is housing. If somebody is homeless and they're wanting to change their lives and they actually are able to engage in our treatment process, I think everybody in the room knows that there are not a lot of options for that person. There are a long wait list. We don't have a way to help that person stabilize in their housing, which means that we really struggle with engaging them in treatment and keeping them engaged in treatment sometimes for that issue. We have a lot of folks that really need a higher level of care than we have to offer, and all the residential programs in our community are full and have lengthy wait lists. So a lot of our time and energy is spent with, we engage with the person that are actually wanting our help. They need a residential level of care, and it may be a month, 2 months, 3 months before there's an opening in that level of care. So we're left with, how do we support this person in a less intensive setting than they really need until they can get into that. So we've started some, again, they're open learning circles specifically around people who are waiting for treatment or pre-treatment groups. And those are primarily harm reduction. If somebody really needs a residential treatment, it's probably not fair to expect that they're going to stop drinking in an outpatient setting. So that there's not an expectation that they become sober to attend that group. We expect them not to be under the influence when they come and they're with us. So we do a lot of connection to community resources. We do a lot of talking about maybe they can reduce the amount that they're drinking or not drink every other day. It's a very harm reduction type model. But it's a Band-Aid. That's not really what they need. It's what we have and what we're able to provide in the interim. And the other place we really struggle with is detox, particularly for a chronic alcoholic. It's very dangerous to just stop drinking. And beds in detox programs are very limited. They're almost always full. There's almost always a wait for that. So somebody comes into us asking for help, and we're put in this difficult position of, you want to stop drinking today? If you do, you may die. So do we tell them to continue drinking until they can get into detox? Do they go to the ER, which is not as well suited to help with this particular medical problem? And there are no good options for somebody who wants to stop drinking and may have to wait a day or 2 days a week to get into a setting that can help them do that safely. And by then, sometimes they still want to stop drinking, sometimes they don't. Sometimes they're back into their routine, and we don't see them again. They pop back up months down the road, and then we're left in the same difficult position of, in this moment in time, they're wanting to stop drinking, and we don't have the ability to help them do that safely.
I might just add, I talked about complexity briefly, and I didn't mention alcohol withdrawal, and I probably should have. I mean, it's one of the only substances we have that quite literally has a life-threatening withdrawal. And without programs specifically oriented towards trying to help people detox, you're left in just that dilemma. I mean, either you keep drinking until you can get into a detox, or what else you're going to do. A lot of times people do end up in the medical system kind of in the wrong way, if you will, or too late, right? Someone calls 911 after they fall down because they've had a seizure, or they have something called delirium tremens, which is often requires chemical sedation to the point where you knock them unconscious in the ICU. I don't have to tell you how expensive that is after 2 weeks. But all of that could be easily averted if we had good access to detox programs that were geared towards, again, I'll just say, coming from Boston, unfortunately, to say the truth, I'm not sure how their detox programs were supported, but I know I had a sheet that was like a page and a half, all of detox programs. And, and it's actually relatively little cost for what they are. I mean, they compared to what they overt, they're medically quite simple and uncomplicated, if you will. You can run a detox with just very limited medical presence even. One person, of course, needs to kind of, well, anyways, I won't go into it, but I'll just say, I'll just highlight that as definitely part of the complexity and a big piece of the puzzle.
So in these cases, again, we see people kind of come around the circle and they show up and want help, and we're not able to give them the help that they need in that moment. Because we don't have that type of care in our system, and we do our best to kind of band-aid and provide them a bridge or options to support them. And when it comes down to it, that individual's choice in that moment is to continue drinking, maybe a little bit less if they're able to, or stop and face potentially some pretty serious health consequences. So my staff really struggle in that moment with what to tell people. As a chemical dependency counselor, and it's very difficult to say, you may need to keep drinking in order to not face these potentially life-threatening withdrawal symptoms. It's a very difficult place to be in as a provider. So those are our major challenges. And for our intensive outpatient program, we have a wait list. So we have these same types of supports, pre-treatment supports for people who are waiting to get into our treatment. And we've doubled in the last couple of years our capacity. We're working on increasing that capacity again, and at least so far we don't see an end in sight in terms of how big would we need to be to not have somebody wait for those services.
Ms. Gray Jackson, this question.
Thank you, Mr. Chairman. First, I want to thank you for the presentation and also for your service within our community. It's applauding. I have several questions. Okay. You said you have 80 programs and 1,700 employees. Is that throughout Alaska, or is it just Anchorage?
It's in Anchorage, the Mat-Su Valley. We have clinics in McGrath, in the McGrath region, and in St. Paul. We have a clinic in New Lavina, which is in the Oyamna Lake area. And we also have providers that go to the rural Anchorage service unit. So the 55 villages that don't have a primary care center, we have providers that go to those areas. Not behavioral health providers, but medical providers that go to those areas. And we also serve the 7 SERI villages.
If I can follow up, Mr. Chairman. So who qualifies as a customer owner?
A customer owner is, depending on the program, Alaska Native or American Indian people, or depending on funding sources like our 4 Directions and our outpatient community behavioral health center and our other programs that are funded by the state of Alaska. We see all people.
Okay, if I can follow up, I have 2 more questions.
Go right ahead.
Mr. Chairman. Okay, and so how many customer owners do you have?
We serve about 65,000 Alaska Native people.
That's great. And gosh, I guess I'm a little bit ignorant to somebody who's an alcoholic and just stops drinking. I mean, I'm going to be honest. I thought that you just stop drinking and there's no health consequences. So I was really surprised to hear the emphasis you put on the fact that when you're waiting to go to detox, you can die if you stop drinking. Could you kind of explain that a little bit more in depth, if you don't mind?
Sure, yeah, I'd be happy to. So I'll give you kind of the generic idea of what withdrawal is or what it's about, and feel free to, again, guide me or ask more specific questions. So, with alcohol use, your body habituates to the alcohol itself, ethyl alcohol. It binds to what's called a GABA receptor in your brain and modulates that receptor over time. And so basically what happens is when you withdraw the alcohol, that receptor has become adapted or used to it being there, present, either all the time or a significant portion of each day, say, or whatever it is. And so when it's gone, you experience physiological symptoms in its absence. This happens with many substances, but most substances, while they might make you really uncomfortable in withdrawal, they're not usually life-threatening, but alcohol is different. It's mostly because that receptor plays a part in disorders like seizures. It also can cause hallucinations and very extensive confusion. Usually it's a process. Not everyone, that's kind of an endpoint of the most severe withdrawal. Not everyone gets there. So what happens is within, and I haven't brushed up on the exact hours of windows or whatever that you get symptoms, but in the first 48 to 72 hours, it's quite common to experience shakiness and quite severe at times. You can sometimes I've seen people holding cups before that are spilling the water because they're so shaky. Your heart rate goes up, so you can get tachycardic, which puts extra strain on your heart. During that same time, your blood pressure can reach really unsafe levels. So kind of not only is your heart working extra because of the increased heart rate, but then it's also got a lot more pressure that it's pushing against, which can be dangerous. That's all part of sweating, and nausea and vomiting can be part of the symptoms as well. That's all kind of a sympathetic response. Your body gets, if you think of the fight or flight response, it's that fight or flight response that just gets kind of out of whack. Your body just goes into overdrive. And then it can result in things like seizures and what we call delirium tremens, which is a combination of hallucinations, confusions, and usually leads to some sort of agitation or people just not being able to follow direction and getting really discombobulated, and they can get aggressive and things like that. And it's those situations that if the seizures won't stop, you can't breathe if you're continually seizing, or if you have the delirium tremens, sometimes the most effective treatment you can have is sometimes you try to replace something that will calm those receptors with benzodiazepines, for instance, but sometimes that doesn't work, and so you actually just have to sedate. So you put them under general anesthesia in the ICU to try to do the best you can to let the process occur kind of sort of safely. But delirium tremens has a very high mortality rate. It's got to be 30 or 40%, I would guess, something like that.
Thank you. Mr. Chairman, just one more two-part question.
Absolutely.
Thank you. All right, so you said that you reach out to the homeless, okay, and then you also talked about a large waiting list. First question is how large is the waiting list? And then to follow up with the waiting list, so when do you determine when it's time to reach out if there's a waiting list? You know what I mean? Thank you.
So maybe I can clarify a little bit. The waiting list is for our intensive outpatient, kind of more traditional program. We provide, right now, just 3 days a week. Fairly quickly, we'll go into 5 days a week, same-day access, kind of a brief support that doesn't have a wait list. They can come anytime, any day that they want. And so the wait is just for the intensive outpatient, or for residential programs, which, aside from women, we don't have an IRS. So these other services we're talking about, the co-located psychiatry, the grief intervention, ESPER, there aren't waits for any of those things.
Thank you. Thank you.
And I would add too that we have actually recently redesigned some of our systems so that we can reduce those wait times in our intensive outpatient.
Mr. Trainee and Ms. Jill, I first want to announce that Ms. Assemblymember Dabowski has joined us during that presentation.
Sorry.
This committee doesn't just deal with alcohol, also drug abuse.
Okay, great.
My concern is marijuana is going legal next year. Are you guys geared up for that? Because there's a lot of people, I think, will increase the demand on your services when marijuana goes legal. Now, does it have the same receptor problem that alcohol has, or is it more addictive in a different way or less addictive?
Different receptor profile, different chemicals. So yeah, I would say thankfully no kind of life-threatening withdrawals, anything like that. Although, so yes, so quite different. And I think there's a big unknown out there, right? Like, even though there's been states that have legalized marijuana, it's hard to say whether we're ready or not, because I still don't really know quite what to expect. I mean, I think you're right. It's clearly there will be more folks using marijuana. How many more folks will be interested in treatment for that, though? I don't know, But yeah, I think we're actually well positioned. That is, I think the best thing you could do for your system is make sure you have really good access to mental health, so that if people do start coming through in larger numbers that want it, it's available and they can reach it. Access is one of the biggest keys, I think, to both treatment and mental health, along with their volitional willingness to go ahead and engage in treatment. And so we do have great access to services. Our BHCs are everywhere in primary care and in the emergency room, et cetera, et cetera. So I think we will capture those folks who are coming through and wanting
So you operate via all the emergency rooms, not just the Native Health Center or anything like that?
we're speaking specifically about our system, which is South Central Foundation. So it is the ANMC campus is what we're speaking about. So South Central is kind of the outpatient side of that system. We do have ANTHC, who is the inpatient, and together we make up the ANMC campus. So ANTHC is our sister company, and so it can be kind of sort of confusing, but basically what we do is we have the BERT team on the outpatient side, but we actually send them over into the emergency room in the hospital to help customer owners who need help with those substances.
So if somebody gets transported to one of the other
If it's outside of our system,
would
we wouldn't know
they
anything
call
about it.
you, or
They might.
how would they get some service?
They might just be serviced, right? If you go to Providence, Alaska Native or not, you might just get the services through Prov. It's an independent system. You would have to use the usual billing and insurance and all that kind of route there. Our services do not extend to their campus per se. If you want to be treated in the Alaska Native People's Healthcare System, you need to make it to ANMC campus. Does that make sense?
One more, in terms of, and I'm going to ask this hopefully for everybody, what's our role? What is the government? Where's the hole that we need to fill?
Yeah, so I would say that, so if I had a magic wand and I were part of your guys' team, especially being a health services guy, my background is looking at all of healthcare, assuming that, from outpatient to inpatient to whatever, right? So from your guys' standpoint, I think of you guys as being payers for, Medicaid, plus or minus. I know there's some details there where it might switch over to federal payments, but nonetheless, Medicaid, the healthcare system of sorts. And I would be upset that we're talking, when it comes to substance use, one, they're one of the most expensive disorders to care for in a healthcare system, and they cost you more if you're not properly set up to treat them. So what happens is, if you don't have the front end services, the detox, the substance counseling, the medication-assisted treatment options, somebody who's going to go out into the community and try to engage them and generate those relationships. If you don't have all of that stuff in place, you end up catching them in the emergency room. They end up in the ICU. And you're fronting the bill for that, which is orders of magnitude larger if you're doing it that way compared to if you just take that money and put it up front. Does that make sense?
Can I just add, they also end up in jail and the legal system.
Yeah. Exactly. No, really, and there are really progressive systems out there who have taken correctional systems and healthcare and housing and all the psychosocial supports that you would need, case management, and kind of combine them all together. And those are the most successful systems, actually, because they can see right away the dollars and cents that you're saving or spending in inappropriate places. So if you can keep people out of jail inappropriately because you're getting them good treatment, you can also keep them out of the ED, the ICUs, etc. But yet, and there's quite good national examples of how you can do that kind of program. But it takes a little bit of rethinking. You have to stop. Psychosocial funding is over here, healthcare funding is over here, corrections funding is over here. Think comprehensively and globally and put it all kind of together, if that makes sense, and help support programs in that manner.
Can I also?
Yeah.
Mr. Chair, there's also significant lack of substance use services across the state, and in Anchorage being the largest city in Anchorage, I appreciate the behavioral health providers that are here today, knowing that with most of us bill Medicaid, and the systems and the structures don't allow for organizations to break even. It's a very even operating very lean. It's hard for providers to get started in this business because you don't break even. We're fortunate. We get funding from the Indian Health Service which allows us to offer these services to our customer owners. But given the state of the state, giving cost increases every year, the rates don't increase. I don't know when the last time the substance use rates have increased. It's a field where we expect if things don't change that providers are going to be shutting their doors, which is going to make what we can offer in this community even We are also partnering with other organizations. This is a community issue, and with South Central Foundation, our expertise is in healthcare, and we rely on many partners. The Mental Health Trust Authority, the state of Alaska, we partner with the Rasmussen Foundation through the Recover Alaska initiative, looking at innovative ways that we can, as a community, meet the needs of not only Alaska Native people, but all homeless and chronic inebriates in the community.
Mr. Pearson and Mr. Chairman.
Thank you, Mr. Chairman. Dr. Coleman, you mentioned a type of drug, benzodiazepine.
Yeah.
I'm not familiar with that. Is that the name of a specific drug, or is that a classification of drugs?
It's a class of drugs, and it's a drug that would be used to help detox folks. So it's, when I tell people what it is, it's kind of alcohol in a pill. It binds to a specific a little bit different part of the receptor, but it binds to the same receptor that alcohol binds to. And in fact, they have many of the same effects. If you take too much of a benzodiazepine, common names for them would be Ativan or Klonopin, Xanax. I think a lot of people have heard these medications, but those are the ones that you would give. So what you do is you tell someone to stop drinking, and then you give them one of those in a structured manner where you can observe them and measure their blood pressure, make sure that they're detoxing safely. But basically what you do is you give them a benzodiazepine to take the place of alcohol, and then you slowly decrease it so that their body has time to get used to it in kind of a more comfortable manner over time, and you reduce the risk of the high blood pressure, the seizures, all that kind of stuff.
And those are also fairly addictive, so that's just during the withdrawal, through the withdrawal period. It's not a kind of
it's not an ongoing
medication.
thing. You just, you can detox somebody fairly quickly, actually. It doesn't take long, day 2, maybe 3, something along those lines. So it can be a fairly quick process.
Good. Thank you. And just to back on the marijuana subject, I've heard anecdotally that some people self-medicate with marijuana to try to get themselves down off of the amount of alcohol they're drinking. Is that something that people do, to try to help themselves?
Yeah, it's not usually something I hear about in the context of alcohol use per se. I think of it as kind of separate, but you will tell, people will frequently say that they're self-medicating either pain or anxiety with marijuana. It's definitely a difficult topic. Most of the studies that I'm familiar with suggest, for instance, that it worsens anxiety over time, that it's not. Although I will say that, there are quite a bit of self-report that people feel like it's beneficial for anxiety. So, it's kind of a gray area, if you will, though I counsel folks that I actually think that over time it worsens anxiety, does not help. But you do hear that self-report a lot. And certainly for pain, there is evidence that not just marijuana, but certain active chemicals in the marijuana, right, that you can sometimes now get via prescription, so that you don't necessarily get the high, but you still get the effectiveness for pain or sorts. So sometimes it is used in chronic pain.
Thanks.
Mr. Train and Mr. Steele. Thank you, Mr. Chairman. Rachel, a question for you. I got 7 grandkids that are VIA certified. They go to the medical center there. So how do you define who can get Native benefits? At what level? Second, third generation, how do you define it? Because Ms. Gray Jackson was trying to figure out how big of a population you deal with custom owners. So how do we define the group that you service?
So our eligibility criteria is if you have a certificate of Indian blood, you're allowed to receive services at the Alaska Native Medical Center, and primary care if you live in Anchorage or the Mat-Su Valley. If you are a tribal member of a tribe, so I am enrolled in my hometown, the native village of Kaliganik, and I have a tribal card, and if I just had that, that would allow me to receive services at the Alaska Native Medical Center.
And my grandkids are involved in Old Harbor, I think.
Yes.
Anyway, you said native blood. Is there some definition? How would you define that? Blood is blood. So how do you define it?
If there is a CIB, the Certificate of Indian Blood, it's on the card, and that's usually given. My children are
1/4 Alaska Native. My husband is non-native, and they have a card that through the certificate of Indian blood, through my mom, through my card, and my children's card. So
My grandkids are the same way, as they trace it through.
It's the BIA.
So through the Bureau of Indian Affairs, you can get a certificate of Indian blood, or if they're enrolled in a tribe and they have that documentation that they're enrolled in Old Harbor, they can present that as being enrolled in a tribe.
So the population's static, so I'm trying to tell Ms. Gray Jackson, as there's intermarrying and children coming on, the population base will grow.
Yes,
Thank you, ma'am.
yes.
Mr. Stu?
In terms of a coordination organization, I went to a meeting that APD had out at their training center that brought together a bunch of providers in the community. And I don't know how official that is or how that structure works. Is there a good coordinating body for providers or service generators? And I know health department has some of this stuff too. So what's your feeling on that? Is there a need for an organization, or is there one that or more that folks work through?
South Central Foundation participates in many, is asked to participate in many community organizations, whether it's health, behavioral health, or substance use, through the Recover Alaska, the Homeless Coalition. In terms of providers, there's many special groups that meet. The Justice Center, we met about a year ago to talk about people coming out of the corrective systems and how we can work together with many agencies. So I think there's lots of groups of people that meet to gather.
In the family, we cross.
Yes, and
It's a
Does
serious-
it work? I guess that's.
It does work. It
concern.
does work. I'll talk about it.
Great. Thank you.
Ms. Gray Jackson had a
Thank you, Mr. Chairman. Just following up on Mr. Trainey's questions and comments about qualifying. And you said a certificate of Native Indian blood. Is there a percentage that's required to qualify? Or is it just, really? There isn't a percentage? Okay, thank you. Thank you, Mr. Chairman.
Mr. Peterson?
Thank you, Mr. Chairman. And I just have to ask this, if the state of Alaska would opt in to expand Medicaid coverage, would that be beneficial to homeless people in regions across the state?
yes, be very beneficial to what we provide and the community.
It's not a magic bullet cure-all, but it would be hugely beneficial in terms of ability to provide the funding to expand services, so we're not dealing with so much of the wait list and able to provide services as on a more timely fashion.
Great, thank you.
Quick follow-ups. The ACT teams sort of that you mentioned, how many do you have that are doing that, and is that a continuous thing that you can operate?
Yeah, so an ACT team is more of a model. We do not have an ACT team here in the city per se that I'm aware of. It's possible we do. Okay, someone's shaking their head. Yeah, so it's quite possible that that other organizations have one out in the community. You know, a lot of it is kind of funding based in the various communities that I've been through. You know, Boston and Seattle and different places. But you know, it's frequently the state that sponsors those kinds of things. Again, like I said, because of the sense it makes dollars and cents wise and other.
Mr. Chairman, we have community case managers that don't exactly do what the ACT team does, but we've been very successful with our many of our programs, such as the Kiana Clubhouse. Many of those customer owners use substances. Many are homeless, and at that program, we offer behavioral health and primary care on site, as well as intensive case management. And our studies have shown significant reduction in ER use, significant reduction in health indicators, as well as significant decrease in recidivism to API or to the
to jail with our probation officers.
Yeah, so Q House is off-site, it's downtown, it gives folks a place to be, it's a clubhouse model, meaning, you know, if you give them shelter and a place to go, they're gonna come hang out. And through that hanging out, you can engage, you can address some substance use, you can do all of those things.
It's not specifically a substance use center, but the comorbidity is so high that
Hi.
a fair number of this population are there as well.
And Dr. Coleman, you mentioned the sort of the coordination aspect of this between various types of services that are needed, and that's, and I appreciate the comment because obviously as we've been looking at this, it's to the outside person, it seems like just a really a jigsaw puzzle that's kind of hard to figure out how everything fits into place. I think from your testimony and others we've heard before, we were convinced that there is a shortage of detox facilities in our community. But my next question is, it seems like that next group after the detox, the people, the case managers and the certain counselors that then work with these folks, there seems to be a lot of those. Now, is that an accurate assessment, or is that a shortage too, or how
There's a shortage there as well. So I think, an ideal world, somebody would, in a chronic alcoholic decides, I want to stop drinking, would go to detox to resolve the lethality, the medical issues of getting the alcohol out of their system, and that's not enough. They're not, if that's the end of the solution, they almost certainly will go back to the drinking. Now, if there's at that point, and this happens now, they do a lot of work around, okay, that person may very likely need a residential treatment center. Now there's a wait list for that. So do they hold them in detox until there's a bed in a residential treatment? If not, do they release them and then they go back to drinking and then have to go through the whole circle again? The way it is now, all these different things need to line up very well for somebody to actually go to detox, to residential, to an intensive outpatient, and gradually step down their level of care. It's very challenging as a provider to help somebody negotiate those things with the wait lists as they are.
There's a big movement in integration, and this is kind of an analogy where, I'll just keep it brief, but say that, we figured out over time that mental health needs to be treated, it's important. And it turns out it shows up in primary care, but we always had these siloed systems, right, where mental health is over here, primary care is over here. So finally, we're now getting to the point where, guess what, we combine them and we treat it all right there. So same thing here, ideally, you could have someone detox and you have a counselor right there so that if you had that sort of opportunity that they really wanted to get sober, you could start them with whatever variety of services they needed, but you could start them on a med, you could start them with counseling. Maybe you have a residential type program that gives them, or a shelter that gives them a sober place to sleep also, right? And then you can connect them with some sort of transportation, right? We had a program that used to give vouchers, right, to people who were in recovery. And so basically it was like allowing them to have money, but they could only spend it on whatever the voucher was. And the vouchers only had certain choices, which was you could go get eyeglasses, you could get medical care, you could use it on transportation, but you could not go out and buy another drink with it, right? And so, it's about bringing all of those services, to, for instance, our clubhouse or something where, we have somebody, a place where they can meet or something that they need, and yet can get kind of all of those things all at once, if that makes sense. I mean, that's where you would really be
One-stop shop.
successful. Yeah, exactly.
And just to follow, and in these meetings, we have Mr. Jenkins with the mental health, and we have Keela House represented and service providers. We've had these different silos that have spoken to us and have participated in our meetings. The initiation to get these places coordinated, does that begin with each individual provider expanding its services or deciding to work with others, or what is the best way, if you have an opinion on it, to get these various entities actually coordinated so you have one-stop shop?
So I think that's a really, in some ways, it's kind of a $20 million question, right? And I would say historically, part of my view is that a lot of it has to do with this idea of carving out different funds for different folks. There's no, you need kind of a funding source that supports putting all of this stuff in one place, that kind of pays for it all at one time. Again, not segmented out. I don't know if that makes any sense, but it's the reason why the system has developed like it has developed. Does that make sense? Is because we kind of say, oh, we'll pay for mental health over here, we'll pay for the substance treatment over there, we'll pay for housing over here, we'll pay for transportation over here. So what we're left with, like in the grant world right now, they're trying to combat that a little bit. And what they're doing is they're now releasing, and this is for the past 5-10 years, right? They've started releasing large grants that require you to partner in the community, right? Which is good intention, and yet we all know the time, energy, coordination effort that it takes to involve multiple, what started out as separate entities or services or right? It's hard enough to have in your own house, have order enough and functioning at a high enough level to get everything done, much less start reaching out and trying to come up with a project with 5 different organizations. It's like, wow, yeah, that's going to take time. So at any rate, people are making movement in that direction, right? They're saying now, Grant, oh, you have to go out and find 4 other community resources, and you guys have to partner before we're going to give you this money. But really, upstream, you need to change that pattern so that from the very beginning, it's like, hey, we're going to create a new organization that actually has a piece of all of these internal. Does that make sense?
I could give you an example
Yeah.
from my hometown in Salt Lake City and Salt Lake County. What they ended up doing was kind of a twofold approach from a government perspective. They took over the detox and the assessment portion, so those are county run, and then they refer from there out to the various providers at different levels of care. They also took money out of the judicial, the corrections, and the healthcare systems within the county and provide housing. There are no homeless people in the county of Salt Lake anymore, because not from a perspective of necessarily helping those folks, because it's a heck of a lot cheaper for the county in the long run to provide the housing, the detox, and the referral. So they took that part, the initial part, as a government system, and then provided the case management for when the detox was done. They have a safe, sober place to stay. What is the treatment beyond there, and referred into the community agencies from there. So there are a lot of different ways to go about it, and that's one that's worked well for them.
Thank you, Mr. Chairman. Did I hear you say that there's no homeless in Salt Lake City?
Salt Lake County, no.
Really?
And anybody who wants a place to live has a place to live. And they did that from fiscally conservative. Utah's not a liberal bastion by any means.
No, I understand that. As a matter
And
of fact.
they're saving a lot of money as a government by doing that, because they're saving money in the legal system and the correctional system and the
Right, and I've
medical
seen
system.
some things about Salt Lake. As a matter of fact, I'm on the board of directors for National League of Cities, and Ralph Becker, who's the mayor of Salt Lake City, is now our president. Mr. Traney and I are going to be there next week. We're going to have a lengthy conversation about this. So thanks for reminding us. Right?
Any cousins, we can send them to Utah.
Just last question. You mentioned and you mentioned how difficult it is and how cost inefficient it is to set up these programs and that they don't pay. With the IHS providing funding for some of the services you do provide, would it be possible, if the numbers worked out, for you to expand into some of these to detox or substance abuse treatment residential? And if you did, would that be somewhat funded by IHS?
So right now, South Central Foundation partners with our sister nonprofit, Coconut Tribal Council, that does the detox in our sister of nonprofits. But South Central does partner with them. We provide the medical oversight for the Ernie Turner Center, and we partner closely. So until our sister nonprofits, we try not to duplicate each other's services. We try to support one another.
I would also say though that IHS, while we're lucky to have that as a resource, I would say that they underfund mental health more so almost than Medicaid or other programs does. So the short answer, I would argue, is still no chance. You know what I mean? Unfortunately.
Thank you very much. It was very informative. Obviously, you had a lot of questions, so appreciate your time, and thank you for coming.
Great, thank you.
Appreciate it. And that took care of numbers 3 and 4 on our agenda, so we're down to number 5. We have a presentation now from Denise Morris, the president, and Greg Razzo, the vice chair on the board of directors for the Alaska Native Justice Center. Folks.
Can we sit right over here
You
and
can
maybe
sit
have
wherever
Ted
you
Bowski
want.
join the crowd?
We only insist that
I
Ms.
marched
Dabowski
around.
stand.
Got it.
Come on up.
Got it.
She's in the back row.
I'm the troublemaker that sits in the back.
We'll join you then.
Right, come on up.
My name is Greg Razzo. I work as a vice president of government contracting over at Siri. And Siri also allows me to do a liaison role and support role for all of the Siri nonprofits. So what that means is for Siri, and this is kind of important for people to understand because I don't think people really understand what Siri's role with all this social service stuff is. So under the Alaska Native Claims Settlement Act, the act created the corporations and they charged them with not just economic responsibility for shareholders, but also social and cultural responsibility for shareholders. So we have to be worried about more than just making money. We can do that part of it. But long ago, the board of Siri decided that the social and cultural part should be apart from the business side. And so consequently, with the assistance of a statute, a federal statute called the Indian Self-Determination Act, Siri, for this geographic region, was able to have tribal authority. We're not a tribe, but we have the same authority as a tribe with respect to applying for funding from the federal government. And that's really what we're talking about. The federal government does provide a lot of funding for all of the nonprofit services, with the exception of our Siri Foundation scholarship. But we delegate our tribal authority to the boards of each of the nonprofits, and those nonprofits are the South Central Foundation, Cook Inlet Tribal Council, headed by Gloria O'Neill, the Justice Center, the Alaska Native Justice Center, headed by Denise, Cook Inlet Housing Authority, which is a native housing authority, and you guys are all familiar with its work, and that's Carol Gore. And then we also founded a group of nonprofits. The first was the Native Justice Center, where we don't actually exercise control, but we sponsor it with assistance and money. And Kiwanis Broadcasting Agency, or the radio station, we also started that and we sponsor that. And then the Alaska Native Heritage Center. So we take this responsibility for social and cultural needs of our shareholders, not just our shareholders, but of Alaskans, very seriously. And each of these nonprofits has grown into models of how you perform services for your customer owners, for your participants, for your clients, whatever the name is. We end up serving quite a few people through the nonprofit family of Siri nonprofits. So I'm here because I have an interest in justice. I practiced law in Kodiak for 21 years, served on the assembly down there, so I know what a lot of material and reading is involved with. But justice is something that Siri really allows me to do, and I sit as a commissioner on the Alaska Criminal Justice Commission. I'm on the Commissioners Reentry Council, I'm president of Legal Services, and on the board of the Alaska Native Justice Center. So having this intersection that you guys are talking about between social services, between justice, between medical services, social services, employment, housing, all of those things are things that we try to do in the family. And it's difficult to do because you do have to try to coordinate all these streams of federal funding which come from different agencies in different amounts with different priorities every year. But we communicate with each other in the nonprofit world, and Siri oversees all of this. And so that's what allows, I think, that mutual cooperation between the family of nonprofits, where especially at Cook Inlet Tribal Council, that's our nonprofit service center. There you go, and you get the social services, the employment services, the substance abuse services of Cook Inlet Tribal Council, or the justice services of the Justice Center, the educational and cultural services of the Siri Foundation, and you can volunteer at the radio station if you want. So it's a lot of stuff all in one place. So when somebody comes in, they're assessed and they're sent to a team of folks that will work with them no matter what the name of the nonprofit is. So today I'm here to talk about the Native Justice Center, which has been around for a long time. I'll let Denise give you specifics about that, and then just chime in if there's any other policy level issues that you want to talk about. I do think that our justice system reform has to happen. I do think we need to reinvest the money we're spending right now on putting people in prison and using that for better purposes. And that means taking a look at our criminal laws and statutes. It means taking a look at the policies we have and charging offenders. It means taking a look at how we support people once they get in jail, so that when they come out of jail, they do something besides want to do another crime. I'll let Denise talk about that.
I also wanted to introduce Venus Wood. She's here with us today, and she's the manager of our reentry program at the Alaska Native Justice Center. And I do want to thank you for convening this meeting. This is a very important topic for our community and a very important topic for the state of Alaska. And unfortunately, it does adversely affect the Alaska Native community disproportionately. As Greg was saying, I'm the president and CEO of the Alaska Native Justice Center. I'm also partnered with South Central Foundation as well, and I'm a customer owner and work collaboratively with the team over there, and we're fortunate to have them as a member of our team. A little bit about the Alaska Native Justice Center. It was established in 1993, and its mission was to promote justice through culturally based advocacy, prevention, and intervention initiatives to restore dignity, respect, and humanity. That was our overall arching goal. And at the time I joined the Alaska Native Justice Center, which was about 1987, I believe. At any rate, when I joined the Alaska Native Justice Center, one of the things that I became keenly aware of was the overrepresentation of Alaska Native women as victims of violent crime. You know, Alaska Native unfortunately has the highest statistic for sexual assault, domestic violence, and child abuse, and Alaska Natives are disproportionately represented in that statute. And we started the Alaska Native Women's Coalition. We acted as a catalyst and a convener, and we brought people together, not to really point fingers and say what's not being done, but bringing people together to say what is it that we can do? How can we work collaboratively together to address some of those particular issues? The Alaska Native Justice Center, for its efforts, won the National Victim Crime Service Award as being one of the first organizations that ever came together to address violent crime against one ethnic group. We started the Meet and Greet initiative downtown, where we went down and shared messages with individuals about safety tips, and we continue that Meet and Greet initiative through today. Another area that we became keenly aware of was the overrepresentation of Alaska Natives within the justice system. And not in a positive way, that we had law enforcement officers, that we had probation officers, that we had court clerks, that we had judges. 47% of the incarcerated population was Alaska Native. And when you look at the age of individuals under the age of 18, that was disproportionate academic numbers of the number of individuals that were incarcerated. So our board tasked me with what can we do to, one, address the overrepresentation of Alaska Native women, children, and men as victims of violent crime. What can we do to reduce the numbers of overrepresentation of Alaska Natives in the justice system, not only at the adult system, but the juvenile system. And the other thing was acting as a catalyst and a convener to address the issue with Office of Children's Services, and the fact that almost 50% of the youth in out-of-home placement with the Office of Children's Services were Alaska Native youth at the time. So those were really three big things, and I said, oh, what else would you like me to do? So at any rate, we really did rely on our partners. We realized that in order to really address these particular issues, that ANJC was going to have to reach out and be a catalyst and a convener, and not always be the lead, but sharing ideas, bringing the community together to collaborate, and really recognizing that these aren't Alaska Native issues, they're community issues. And I can really say just about everybody that's here in this room, I've reached out to, I've worked with, I collaborate with, we work together. I have no problem asking for help from absolutely everybody. And funding. I always have my hat in hand, so generally when you see me, I'll probably say, oh, and we're having a fundraiser, by the way. They just go hand in hand. There's just no way of getting around that. But I do want to share some information with you today about our adult reentry program. And the Alaska Native Justice Center began doing our adult reentry center back in 2008. And being a catalyst and a convener, we're a 501c3, so we can't lobby, but we can certainly educate. So under the Bush administration, we were one of the groups from Alaska that went down and was working with the coalition team to get the Second Chance Act passed, so that would be federal funding and federal recognition of the incarceration rates across Alaska. And we were really reached out to the faith-based groups. The faith-based groups at the national level is really what ended up getting the Second Chance Act passed, because they've been doing this work for a long time, so I do want to give them credit. But it didn't really have a name. It was just, you're supposed to help your brother, you're supposed to help your sister, and that's basically what they were doing. So in 2008, we got a grant through the Bureau of Justice Assistance and formally started our reentry program. And with our reentry program, what we do is we work with individuals that are incarcerated either at the misdemeanor level and or the felony level. The three places that we primarily work with, the downtown jail, Highland, Allman Correction, and now Goose Creek. And we work with individuals in a perfect world 4 months pre-release, and we put together an intensive case management plan based on what is referred to as an LSIR, which is a needs assessment. So what we want to be able to do is when those individuals transition from incarceration, we have a reentry plan in place. What are their conditions of probation? What are their conditions of parole? Where are they going to get their first week housing? How are we going to get them into alcohol and substance abuse treatment program? How are we going to get them employment? All of the issues that people address.
Ms. Morrison, Ms. Jackson has a question?
Thank you, Mr. Chairman. Sorry to interrupt, but I had the honor of going to Highland Correctional Center and speaking to about, 35 women. And it was just like one of the best experiences I've ever had in my life. And one of their issues was in terms of recidivism, hard word to pronounce. Anyway, is getting out and wanting to change their lives and then not having housing. So I'm really glad to hear you talk about your program and that you do work with women at Highland. But how, and you did mention housing, but is housing assured when they get out? I mean, so it's not, okay.
There's no, I would say if there's a gap, one of the major gaps that we have with individuals that are transitioning from incarceration is housing.
Right, and that's what they said. Thank you, Mr. Chairman.
It is, and when we're talking about recidivism rates, just to share with you, the highest recidivism rates occur during the first year after returning to the community. Yeah, 35% of misdemeanors will be reincarcerated, and 27% of felonies within that first year time frame. So that really is kind of the critical time frame. If individuals can make it over that 1 year, the likelihood of them being reincarcerated is greatly reduced. So what we try to do with these individuals through intensive case management planning, pre-release, is that when they are released, they've already built a relationship with their case manager. We already have a plan in place. They're committed to the plan. They're signing on the dotted line indicating that we are committed to working with. We want to change our lives. So we do provide intensive case management, which is one-on-one case management. Everybody that's on probation and parole, we have an agreement with the Department of Corrections. Everybody is assigned to one probation and parole person, so we don't have to bounce around. We have one person that works with us. When we're talking about coordinated wraparound services, we do weekly case management meetings with everybody that's providing services. So we get Aquila in the room, Cook and the Tribal Council in the room, Alaska Native Justice Center, Rural Cap, they're providing services. Whoever is providing services to this core group of people that we're working with. And really what's working, what's not working, where are the barriers, what do we need to do, and how do we continue to support these individuals. One of the other things that we require of individuals is 40 hours of community work service. We really feel that going back to the community as a whole requires for these individuals to give back to the community. So they will go community cleanup, they will Habitat for Humanity, serve food at Means Cafe, lift boxes at the food bank, but they're all required to give 40 hours of community work service. The other key component of ours is peer-to-peer work group. Everybody attends a weekly peer-to-peer team work group. So I may not know that an individual that's telling their story is not telling it quite accurately enough, but the other members of the peer group are going to say, no way, that's not true, that didn't happen. So they do hold each other accountable, and I think that really adds to our success rate. Well, the state's recidivism rate is at 75%. Individuals that come to our program or graduate through a program, our recidivism rate is 27%. So through the intensive case management, the peer-to-peer support groups, and I think the other thing is believing in these people. I think that when we sit down, we do a graduation when people graduate from the program, and for a lot of these individuals, this is the first time that they have ever graduated from a program. This is the first time they have ever completed a program. And one of the things that we do is that when we have individuals that graduate from the program, we bring them back so that our case managers that work with this population, the majority of our case managers are individuals that have at some point in their life been incarcerated.
When somebody comes in for an intake too, there's an assessment that's done, and if they need to go see the folks at Cook Inlet Tribal Council for detox or outpatient or residential treatment services, they're referred over there. If they need to go see one of the other sister services, that's where they get referred. And then in terms specifically of housing, homeless housing, predominantly it's done through sub-grants through Cook Inlet Housing Authority to Covenant House, Catholic Social Services, and other organizations like that. But I would say, I think it's fair to say that while it's something that all of the CRE nonprofits are aware of and looking for funding for, that there's not a lot of funding available for it. And when there is funding, we try and partner with each other.
And with our program, as Greg was indicating, we really do try to provide total and complete wraparound services to the individual to meet their needs. One of the areas that we do know is with mental health issues. A lot of individuals that are currently incarcerated may be receiving meds while they are incarcerated and some level of mental health services. So it's really important that we're able to connect with South Central Foundation and other organizations to ensure that those mental health services, that there's not a lapse in those mental health services. The other area that we do have is what individuals are indicating is alcohol and substance abuse to get individuals into support groups. That's an ongoing issue. Housing is a challenge. I think even for individuals that haven't been incarcerated, housing in Anchorage, rent prices are expensive. And when you're looking at first month, last month, and a security deposit, and gas, electricity, utilities, it is a barrier for individuals in that position. So we really are cognizant of that, and working with them pre-release, try to have an idea of what it is that they're going to be doing for housing, and working with this particular population. But the key is trying to provide total complete wraparound services, and we reach out to everybody to try to be able to do that. Employment is another area. We work with a number of organizations around employment, and we've been pretty good about educating employers that this is a really good team of individuals that you can employ. There is a certain amount of stigma that's still associated with that, hiring a felon. So there is a certain amount of stigma. So it's an uphill battle for them to be able to get employment. But I always say, okay, let's get a job, and then we'll get the job. We'll work toward that.
Mr. Trainee, you have a question?
Thank you, Mr. Chairman. reference, you said that a large percentage of Alaska Natives are in the criminal justice system. What are we doing to get Alaska Natives in the intake part of that, police officers? Because when I look at APD, I don't see that many natives working there. Do you guys have a program to help the people when we are looking for officers to qualify for the tests and to make sure they're ready to become a police officer? Because I want to get more Alaska Natives in that end of the criminal justice system. We're the largest Native community in Alaska. We need to have more Native Alaskans as police officers. So do you guys have any program to make that happen?
Not specifically. There's certainly no funding that's targeted to do something specifically like that. I mean, we provide at Cook Inlet Tribal Council the general employment services and help people find jobs, but specifically for law enforcement, there's no target for that. But the same thing is true. That lack is true throughout the criminal system. There's not one Alaska Native judge in this state. Not one.
One of my son-in-laws is a principal of College Gate Elementary, and there aren't that many Alaska Natives through the education system. And we need to correct that. So if you need some help, let's see what program we can work together on in getting people ready to qualify to become police officers. Just give me a call and see what we can do.
Sure. And
Because we're always looking for officers.
The other education component is through the Siri Foundation and the foundation funding that Siri has endowed that with to train our shareholders and descendants so that they're looking at targeted jobs. We sponsor their college or vocational training, and that winds up being a fair sum of money. It's about almost $20 million so far in grants and scholarships.
When I talk to EPD, I'm going to ask them specifically, what's your recruiter doing to reach out to Alaska Natives?
We do work with the chief, and we love to.
I know, but I want to get to the recruiter level.
Yeah.
And the chief of police for the municipality of Anchorage, it is a seat on our board of directors, so that the chief of police for the Anchorage Police Department serves on our board of directors. So currently, the chief of police serves on our board of directors.
Thank you, Mr. Chairman.
Denise, do you want to talk a little bit about the program? Share a little bit about yourself.
Yeah, sure. I came to the Alaska Native Justice Center in 2009. I was released from Highland Mountain, and I came as a participant. I worked full-time at Beans Cafe as a prep cook, and worked my way up there to assistant manager of Beans Cafe. And when I graduated from ANJC, I became a mentor. I stayed on as a mentor and did the mentoring program. I helped other men and women that were getting released out of prison. And then they had a job open. I applied, and I became I ran the mentoring program. I became employed, and I ran the mentoring program. And then I got promoted to a case manager, and now I'm the program manager. I'm also, I work very, very part-time still at Beans Cafe. I'm also the weekend manager there. So I see a lot of the same people, the same participants. They get released from the prison, they go over to Beans Cafe, and then we'll see them later on at the Alaska Native Justice Center. It's a great program. Without it, I don't know where a lot of people would be. One thing I always like is when we go to the institutions, I see a lot of the same people that have been through our program before, but they always want to come back, and I always tell them, no matter how many times it takes you, just come back. We're not going to judge you. We just want you to come back, because it takes what it takes for different people.
I would say on average, the number of individuals that we serve at the Alaska Native Justice Center through our reentry program is about 1,200 individuals a year. And that's not to say that every one of those individuals needs intensive case management, but they do stop at our door for support. We'll have individuals that have graduated from the program in years past that come back and volunteer, or they just may feel as though they're at a vulnerable time, and they'll come back to a peer support group, or they'll come back to talk to their case manager. So we always say that, once a member of the Alaska Native Justice family, always a member of the Alaska Native Justice Center family. But it's about 1,200 individuals a year that we provide services to.
It's an interesting time in the state of Alaska right now, because I can tell you that the state and the Department of Corrections is recognizing that they have to do things differently. Their results are terrible, right? And so now it's time to take a look at things like reentry and alternatives to prison. And so that justice reinvestment, where there's less money and using your money more smartly, just makes sense. And it happens, it trickles down, we know, through all layers of government. And it trickles down into those that are particularly not available to access federal funding. But we've had institutions that have been around for almost 40 years now, and having these institutions become stronger, more capable, and taking care of the huge population that they serve, I think is part of the answer.
And one thing about our program is we work pre-release at the prisons, and we do women's group at the halfway house, post-release when they come out of prison, and then we take all crimes. We don't discriminate. We take sex offenders. We take felons or misdemeanors. So it's really, we're open to anyone that has been recently released.
And with our program and the way it's designed, of course, addressing substance abuse treatment is a mitigating factor because that's an issue that needs to be addressed. Mental health services, we make sure that the individuals are linked to mental health services as well. Through Q House and others, we make sure that there's medication-assisted treatment for a lot of individuals that can't manage their own meds but need the meds. Opiate abuse treatment, a lot of individuals were incarcerated because they did have an opiate abuse issue, so we address that. Hepatitis and HIV, when you're dealing with this particular population, you have to realize that hepatitis and HIV with this population is also high, so to make sure that we get the referral and get them navigated into those service programs. Family reunification, a lot of individuals feel as though they're going to be released and once again be reunited with their family. That often is not the truth. So we have to deal with those particular issues and provide those services. Vocational, educational, transportation services. They need to get to all of these places, but they have no means of getting there. The bus service is not free. Vouchers are expensive. Just wanted to say that might be something that you guys could help with. Vouchers, drug testing. A lot of individuals do have to have an assessment to determine where they are as it relates to services. So those services we coordinate through Aquila, Cook Inlet Tribal Council, and South Central Foundation as well. And then the basic needs, when you're looking at food, clothing, childcare, transportation, housing, we coordinate and act as a navigator and a case manager. And peer support, parenting classes. And the other thing that we recognize is not only making the referral for this particular population probably isn't sufficient. So we really do act as a navigator and link people. And what I mean by that is you can tell an individual, you need to call over to South Central Foundation and you need to schedule an appointment with the case manager to get into the treatment program. You need to call over to Aquila and get an assessment. You need to call over to Cook Inlet Tribal Council and do this or that. And what we've done with our intensive wraparound case management system is that we have established a navigation system. So the individuals that we're working with, we can give them a card. When they give that card to the person at the desk, they know that they're being referred to from the Alaska Native Justice Center. And then they're directly linked into those services. We'll also call on their behalf and say that they're coming over. We need to make an appointment, or we'll make the appointment for them. Because just referring them over is not going to get it done. At this beginning intensive case management stage, that's exactly what it is, an intensive case management. It's not hand-holding. They have to be responsible, they have to be accountable. But for this certain period of time, you have to realize they've been in an environment, you will show up and shower. You will show up, you will eat. You will show up for work detail. You will show up for kitchen detail. You will be back in your room at this time. Very structured environment.
Mr. Steele.
Cook Inlet is in an enviable position to a certain extent in that you not only, you're doing well, I think, with the reentry program from all I've heard, but you also build housing. Housing is a need. Is there a connection between the need of folks coming out or even some of the folks that have chemical dependency that haven't been incarcerated? Does Cook Inlet help with housing, or do they provide a certain number, or are they open when you call to helping to find a place for some of these folks that need housing?
So the housing that we do here in Cook Inlet Housing Authority, I think you guys are familiar with that, that's low-income assistance housing. I don't think that's the housing that you're talking about. You're talking about more transitional housing.
Well, I'm just talking about the need for housing for folks, all the folks that we're talking about in terms of.
Yeah, and it doesn't matter if
dependency.
you're in jail or not.
But Cook Inlet builds, Cook Inlet owns.
Right.
And I presume maybe a source, at least for some of the housing needs.
So if it's the same sort of wraparound service that Denise is talking about. If it's identified that there's a housing need on an intake or through the caseworker process, then there's a phone call to Cook Inlet Housing, there's a referral, and eligibility is determined for that particular individual.
Who we use for housing depends on the person and their needs. If it's an individual by themselves, if you have to look at their crime, did they commit a crime against a person? Did they commit a sex offense? Did they? Is it a DUI? So we really have to do the intake, get the background information, and then based on their need, we have about 10 different transitional housing programs that we can kind of pick from, whatever's best suited to them.
Most of the housing vouchers that we utilize for this particular population comes through Alaska Housing Finance Corporation. They have their HAP grant, and so most of the dollars for housing for this particular population comes through a voucher program through Alaska Housing Finance Corporation. There's a few dollars also that come through Rural Cap, Safe Harbor. There's some housing dollars that are available there, but I can tell you for this particular population, when you're looking for housing, it's limited. There's limited housing that's available. And usually by the time you get to June, you are out of dollars for housing, and housing dollars will not be available into the next funding cycle, which starts in October. Everybody out there shaking their head. So usually from June to October, as it relates to housing dollars are pretty much exhausted within this community that provides these services by the end of June. And a lot of individuals, I have to say, through case management, we ask them as far as being reincarcerated, why were you reincarcerated? A lot of individuals will say, I got reincarcerated because I didn't have any place to go. So I would get a bed or a cot and 3 square meals a day. So a lot of individuals just recycle back and forth through on misdemeanors to make sure that they have a bed and 3 square meals a day.
What's the need? What's our role in terms of solving the problem? I know the problem is multifaceted. What do we need to do? What does the community need to do?
Well, I think one of the things that we need to look at is, of course, is housing. And I know that there's been a couple of task force that's looked at housing. I know there was some recommendations that were put together, and maybe one of the things that would be valuable to do is kind of dust off the report, look at some of the recommendations that were included there, and see if there are recommendations that we could do or implement. I think there probably are a few in the different reports that have been published that we could do. I think also when we're looking at barriers, there's a lot of barrier crimes, and individuals cannot access services because of the crime. And I know this commission that Greg's on is looking at those barrier crimes. But if individuals could access food stamps, if individuals could access housing, if individuals could access some of these programs, because right now, currently, there is a lot of programs that individuals can't access because of the fact that they've been convicted of a barrier crime. That would be helpful to look at as well. Transportation vouchers, for individuals to be able to get around town and access services, if there's anything that we could look at as far as vouchers for bus services. I think when individuals, sister organizations talk about the expansion of Medicaid, so there is expanded mental health, substance abuse treatment programs, support for that would go a long way.
Sure. Taking a look at your public safety systems, your health systems, and encouraging partnerships with the nonprofits. Not that it doesn't exist already, but really strongly encouraging those sorts of partnerships, I think, is a good idea. And taking a look at if you guys are spending your money wisely on the existing way that you're doing business in justice in particular. Is that the best way to spend your money in terms of priorities for your police department?
One of the programs that we do have, and just in closing with this, and we're looking at it, is that we have a youth program and we have a community diversion program and offer Prime for Life under 21. And just so you guys are aware, that I think it's valuable information for you to have, is that when we're looking at the number of youth that are coming through, of course the process is changing right now. It was going to the state, now it's going to the municipal prosecutor's office. But when you're looking at the number of youth that are consuming alcohol in our community, it's an alarming rate. And the more youth that we have that are consuming alcohol at a younger age, the more likely that they're going to have an issue later in life is greatly increased. I think if you consume alcohol by the age of 15, the likelihood that you're going to have an alcohol substance abuse treatment as an adult is almost 75%. There's almost a guarantee. So, if we're looking at prevention, I think that's one of the things that would be really invaluable, is looking at prevention programs. If we can be really proactive in prevention, if we can make sure that our youth graduate from high school, it reduces their likelihood of being incarcerated by almost 75%. If we can keep our youth from consuming alcohol or drugs in an early age, their outlook of being a productive member of our community and not suffering from substance abuse issues is greatly reduced. So I think there's a lot of things that we can do as a preventive initiative as well. So I think we have to be here providing prevention, we have to be providing the needed services, and then we have to be providing the supportive services.
Mr. Peterson, you had a question.
Thank you, Mr. Chairman. I was wondering if the Muni were to recreate the homeless street inebriate coordinator position, do you think that would help sort of create a superstructure to maybe get everybody pulling in the same direction?
I don't know the answer to that, because we did it before, and I think that the groups that are here, if we had somebody that was coordinating, I think coordination would be good, but I don't know if we can just look at the homeless population. I think that because the homeless population changes all the time. People are homeless, then they get housing, they're homeless, they get housing. So I think it ends up being a chronic issue that we have about 250 chronic homeless people. And I think what we need to look at is the model that we have. We have a housing, is it housing first model? And I think there's an idea with that housing first model, and that's what I was saying, if we go back and look at some of the recommendations that were there, if we expand that housing first model, I think it could really help reduce the homeless population of at least of this 250 individuals that we have that are kind of chronically homeless. I think there might be a solution. I think there was a task force that put a lot of time and energy into that. I think it's a model that's worked in other states. I think it's one of the models that, where was this individual from? Utah.
Yeah.
It's utilizing. I think Seattle's utilizing, and I think there's a lot of other communities that are really utilizing that housing first model, and it seems to be working.
Housing security provides a lot of answers. It really does. So, we'll leave some general overview for you guys.
Sure.
Yeah.
Just a brief question, mostly for you, Greg. As you know, this committee it has a very narrow focus, much more narrow than what you have to deal with. And primarily, we're talking about trying to find solutions for the 200 to 300 estimated really serious chronic inebriates who are living on the streets of Anchorage. Basically, that's the mission of this committee. Hearing, it was refreshing and good reminder to hear about all the various nonprofit foundations that Siri oversees. They're doing, such great work throughout the city. A lot of times people forget about that and don't, connect the dots as to who that is. Since we were talking about this very narrow problem, do you think that Siri itself and its associated nonprofits and entities could perhaps, by making that a priority too? Now you're already doing a lot, and not saying you're not doing enough on this issue, you certainly are. But if because we're looking for partners to solve this problem, because one thing, it's a very narrow problem, we're talking a few hundred people, but the ramifications of it and the angles on it are huge, and it touches on everything from housing and all this stuff that we talked about. I guess I'm just more or less requesting instead of answering a question. I think it would be hugely helpful if we could up sort of the priority of this issue with you guys as well as with us, and working together perhaps, because it's going to take, just to make a dent in this problem, a huge effort from everybody's part, and I just throw it out there for you to see what can be done amongst your groups that are already working hard on these issues, to see if we can step it up a bit and add some resources or add some programs or restructure something to focus on this.
I think it's entirely possible. That's the reinvestment that I'm talking about. Taking money that you're spending that doesn't seem to be working in one spot, putting it somewhere else. Can Siri help out on that? I can help coordinate so that, and certainly it's not my job, I do government contracting, but what we can do is help coordinate the folks at South Central Foundation that are specifically tasked with housing. They have housing grants. The same thing is true with Cook Inlet Housing and Cook Inlet Tribal Council, and working with the Justice Center. So we can at least convene those folks that know what they're talking about, know where the money is, and are interested in working with the municipality. We can do that.
Perfect. Any other comments? Thank you very much for coming. It was very,
for your time.
Very informative.
I'll leave an overview back there for you guys.
Thank you.
Thank you, Mr. Bowser.
Well, it's time for member comments first, and we'll go around the room and see if there's any. Ms. Domboski, do you have any?
No, I found the last presentation especially informative. I know I've been on the bandwagon about the overrepresentation of the Alaska Native population in some of the groups that we're talking about. And to finally have somebody other than my anecdotal mind validate that, it to me drives the importance of why we need to have tribal partners and why we need to have so many different groups at the table. So to me, I took a copious amount of notes because finally I have validation that we're on the right track and we're bringing the right partners to the table.
I'm fine.
Like Mr. Bosky, I wasn't aware of all the efforts that you were making, and I'm very happy that you're making those. And it's a little frustrating that finding out that you're doing all that and we still have the problem that we have, it just makes it that much more difficult to figure out a way to get over the top on this deal.
Thank you, Mr. Chairman. As I mentioned earlier, my visit at Highland Correctional Center just really opened up my eyes. And on a personal, I will encourage everything I can to help these women come back and re-enter into society and be an asset to our community. So, and thank you for your presentation. Thank you, Chairman.
And members' comments, we have time for audience participation, so if there's anybody in our audience that has any comments, questions, concerns.
I have a question for you. I had to leave the room because somebody left her phone behind, and you may have said this when you first started presenting. How do you contact people in jails and in halfway houses. Do you go and talk with each of them?
Do you want me to
So-
answer? Yeah, okay. So we, yeah. Are you talking about the inmates or the jail?
The inmates.
Okay. So with the inmates, what we do is we have a regular schedule. We've been going out there for a long time. So we meet with, like at Palmer, we meet with anyone getting released in the next 6 months,
Okay.
getting released to Anchorage.
What about someone who has a DUI who is in Cordova Center?
Okay, so what we do is we have established relationships with the halfway houses. We go around maybe twice a year and do kind of a generalized presentation about our program.
But you don't speak to the individual inmates.
No, we do, so I'll answer the question, and I'll stand up so I don't have my back to everybody, and hopefully everybody can hear us. So the first thing that we did when we started our reentry program is we reached out to the Department of Corrections and to the Commissioner. And we entered into a memorandum agreement with the Department of Corrections that would allow us to actually go into the facility. So we were totally, completely new, and we wanted to get individuals into the reentry program. And the question is, how do you get individuals into a reentry program that don't want to be in a reentry program? And we started with Highland Mountain. And the way that we did it is we sent out little invitations. We selected 40 people within Highland Mountain, women, and we sent them little invitations. And we said, you are invited to an Alaska Native Justice Center reentry orientation. So then it was really special. Only 40 people got invitations, and they were going to get time out of their cell to attend the program. So all 40 showed up. And that was kind of our first road. And then with Highland Mountain, we kept going back, we kept doing it, and the program there was very successful. We worked with the superintendent, we worked with the women's judges group. We started Success Inside and Out, which is supported by Chief Justice Fabe. We worked with them and coordinated that now they have they take care of the dogs during the Iditarod. They have flowers, they have a band, they're doing all kinds of things within the organization. And it was just really kind of being a catalyst and planting that seed that you really can work with these individuals. So now we have an ongoing program at Highland Mountain. We go on a regular basis. Everybody knows the Alaska Native Justice Center is going to be there at this particular time, and individuals are invited to participate in the program. Basically have the same program. After we had success with the women's program, then we expanded our program to include males. So we have a memorandum agreement with the halfway houses, and we go down there on a regular basis and provide services. And sometimes we go there and provide services, so like our MRT, moral recognition therapy, we will go there and provide the services directly and start to develop that trust and that relationship. And then begin to work with the individuals to develop the case management plan.
Well, okay, I'd like to speak as the mother of an adopted Native son. He's 43 this summer. He's been in and out of jail because of substance abuse problems for about 20 years. He has been in many halfway houses here in this town. It's very tough to get down there and talk with him because they have certain visiting hours. I go down to see him and I ask, and nobody has talked with him. He is in Nugent's now, but it's because I and my husband contacted a judge, Judge Rhodes, and said, how do we do this? Now, I'm asking you, he's been in and out of the legal system for years and years, but he's been able to just slip through the cracks, and I know he's one of hundreds. I have sat in the courtroom over and over again. I have heard the judge say, okay, you didn't do your ASAP, so you can pay a fine, and you're gone. Now, you're asking why we have this recidivism rate? It's because people fall through the cracks right there. Right there.
I totally, completely agree with you, and I would say that as I indicated earlier, that we provide services on an annual basis to about 1,200 individuals. But if we were to reach everybody, it takes expanded services and expanded resources. And I've been exactly where you were. I mean, I had a family member that just basically was doing revolving door because of long-term alcohol, substance abuse issues. So I know how it feels.
And the other part of that is these halfway houses, I think, are dens of thieves. You put a bunch of people in there who are in trouble, and they make contacts, they come out of there no better than when they went in. And then, trying to get him into treatment, he needed long-term treatment. He went to ASAP. They said, okay, you need to come in for an assessment next week. And he slipped away. He slipped away from all of us. Finally, there was a warrant out for his arrest, and we said, you've got to go. So he had to go. He was put in the halfway house over here on Park Place. Same kind of thing. Nobody's talking to him. He's just sitting there, serving out his time. And that's finally when we got him into Nugent's, which was, I think, the most wonderful thing that could have happened. I think it's a fabulous place. Anyway, that's my plea. There is a big gap there. You've got to, some of these people you have to kind of take by the hand. And, families can't do it. We don't have the knowledge. We don't know how to get into the system. If I hadn't called Judge Rhodes and begged her for help, he wouldn't be where he is. So anything I can do to give you input, I've told her that I could. So, okay.
We're going to have,
All right.
we have another meeting that's going to be starting in this room in a second.
Okay.
So, just real quick.
So I just want to point out something that was evident to me. Again, I said it to you beforehand, but you heard the guy from South Central Foundation say it again, that the element that is missing is a coordinated approach. And your question about would a homeless coordinator kind of lead to that, and my only suggestion is that a homeless coordinator has a very broad task. There are a lot of homeless people that aren't in this population. And within the Health and Social Services Division, it seems like an effort to create that coordination would be wise. I just don't know that it is tied directly to that homeless piece, because the homeless person is doing the late night shelters and the cold weather and all of the other things. And this is so narrow and so concrete. So I just wanted to, but he said exactly the same thing. And we've heard it over and over and over again.
Petition penetrates even the dullest mind.
Right, yeah. Thank you.
Thank you all. This committee will probably have only one more meeting, it looks like. And it may not be at our regularly scheduled time, but we'll keep everybody who's on our email list apprised of when it'll be.
And that week is the 4th of July week, and so hopefully
It's almost definitely won't be
delayed to
already.
next week. Yeah.
And if you're not on the email list, you can leave your email with me on the way out, and I'll get you on it.
Thank you.